Okay, let's really dig into something we talk about constantly, maybe without ever stopping to question what it fundamentally is: mental illness.
Hmm.
We often picture a clear-cut medical problem, right? But what if our modern understanding is a relatively recent invention, shaped less by pure science and more by shifting social forces?
That's absolutely the core idea we're pulling out of the source material today.
Yeah.
We're diving into excerpts from Allan V. Horwitz's book, Creating Mental Illness, which offers a really provocative argument about how society classifies and, understands psychological suffering.
Right. So this deep dive is all about getting the key arguments from this specific book, quickly and thoroughly. Our mission is to unpack those historical shifts in psychiatric thinking, understand the social and cultural forces Horwitz says are at play, and explore how these shape what gets labeled mental illness.
Hmm.
What are the most important, maybe surprising nuggets from this perspective that you can walk away with?
Exactly. What does this author argue is the critical story behind our current definitions?
So where does this story begin? The source takes us way back before the era of Sigmund Freud, which already feels like stepping into a different world.
It does. And in that world, the landscape of psychological suffering was seen very differently. Before what's called dynamic psychiatry, which Freud was, central to, there's a much more rigid, almost black and white distinction
Right.
between people who are considered insane and, well, everyone else. Suffering was often seen in pretty stark, often untreatable terms.
Then came dynamic psychiatry, Freud's influence, and suddenly things got a lot more complex and, well, blurry.
Precisely. Influenced heavily by Freud, dynamic psychiatry linked what they called neurotic behaviors much more closely to normal, everyday human experience. And here's the critical shift. Symptoms weren't viewed as direct signs of a specific underlying disease.
Oh, okay.
Instead, they were seen as symbolic expressions of unconscious conflicts.
Unconscious conflicts, right, often traced back to a person's history, particularly childhood experiences.
Yes. And this was a major departure. It meant the same outward symptoms, say, anxiety could actually mean entirely different things for different people, depending on their unique personal history and the unconscious conflicts driving it.
Hmm.
Symptoms kind of disguised the core issue rather than simply revealing a specific illness.
So this view wasn't just about identifying and treating problems. It sounds like it expanded psychiatry's reach quite a bit, didn't it?
It did, yeah. Dynamic psychiatry aimed to understand not just abnormal behavior, but also normal behavior, seeing a continuum. It even influenced areas like criminology and education,
Right.
with the idea that understanding childhood conflicts could help explain and potentially, contain deviant behavior later in life.
And the book points out that this approach had a specific appeal to certain groups at the time.
It was quite popular, particularly with an intellectual clientele, especially in urban cosmopolitan centers like Vienna, where Freud worked. The source specifically highlights its attraction for groups like middle-class Jews who, at the time, were sort of navigating assimilation into urban culture and experiencing a sense of alienation from traditional community ties. Dynamic psychiatry offered a framework for understanding individual identity and conflict in that changing world.
That's a fascinating social angle. But despite this influence, dynamic psychiatry didn't hold its dominant position forever.
No, far from it. The source describes a remarkably rapid and dramatic decline starting around the mid-1960s. By the early 2000s, when the book was written, this dynamic way of thinking was often seen by many in the field as something of an embarrassing lapse in the scientific progression of psychiatry.
An embarrassing lapse. That sounds like a pretty strong rejection.
Yeah.
So if dynamic psychiatry faded, what emerged to take its place so suddenly?
What burst onto the scene from the mid-1960s was diagnostic psychiatry, most famously embodied by the Diagnostic and Statistical Manual, the DSM.
DSM, right.
Yeah, you can think of the DSM as the standard handbook that lists mental conditions and provides checklists of symptoms for diagnosing them. The source calls this shift a total reorientation.
Moving from those blurry continuums and symbolic conflicts to what exactly?
To a focus on sharply delineated disease entities. The idea was to classify conditions into distinct, separate boxes based primarily on observable symptoms.
Okay.
Now, while this system is officially neutral about the ultimate causes, in practice, it strongly emphasizes a medical classification and leans towards underlying organic pathologies, things like genetics or brain chemistry.
Right.
The prevailing idea became that many disorders stem from chemical imbalances that could be effectively treated with drugs.
And this pushed biological explanations right to the forefront.
Absolutely. The source says the study of biological foundations gained unquestioned primacy within the field during this period.
Now, it seems this push towards medicalization and these clear-cut diagnoses also sparked a powerful backlash around the same time.
It did. Almost simultaneously, the mid-1960s also saw the rise of the anti-psychiatry movement. Critics like Thomas Sazes, whose book The Myth of Mental Illness was hugely influential, flat out questioned whether mental illness even existed as a medical entity at all.
So how do they see psychiatric concepts then, if not as illness?
They viewed them more as pseudoscientific masks, disguises for value judgments about what society considers good or bad behavior, or even as tools used to enforce conformity to what they saw as a repressive status quo.
And cultural touchstones, I'm thinking like the novel and film One Flew Over the Cuckoo's Nest, they really resonated with this skepticism, didn't they? Depicting patients as victims of the system.
Right. Those narratives absolutely captured a public unease with the power and perceived overreach of institutional psychiatry.
Okay, so diagnostic psychiatry, with its focus on symptoms and categories, becomes the dominant model. How does the system actually go about defining what a disorder is in everyday practice, according to the book?
Well, the core principle is classifying clusters of symptoms into these discrete disease entities, like checking boxes.
Right.
And here's where the source points to a major problem. The system often avoids making inferences about why the symptoms are happening. The presence of enough symptoms, regardless of their context or cause, is frequently taken as sufficient evidence of an underlying disease.
And Horwitz argues this symptom-based approach has a really significant blind spot.
Yes, it fundamentally struggles, according to him, to distinguish between what the source defines as a true mental disorder, which involves an internal dysfunction, and what are actually appropriate, expectable responses to stressful social conditions.
Appropriate, expectable response. So you mean like normal human reactions to difficult life stuff, like getting fired or a bad breakup?
Exactly. The book points out that symptoms like depression, anxiety, or physical stress responses that arise when someone is going through a divorce, facing serious financial trouble, stuck in a bad job, dealing with difficult relationships, or grappling with an uncertain future. These are presented as normal, expectable reactions to difficult external circumstances. From this perspective, they should resolve when those circumstances improve.
Okay.
And crucially, according to the source, they are not indicators of an internal dysfunction.
Okay, so this is a crucial distinction then. The author's definition of a true mental disorder needs more than just ticking symptom boxes.
Yes, according to this source, it requires two things. First, an internal dysfunction, and second, social definition as inappropriate. The internal dysfunction piece is key.
Right.
It's when symptoms appear without an expectable stressor, or when they persist with disproportionate severity or duration after the stressor is gone.
Can you give us a really clear example of that distinction? Like, make it concrete?
Sure. Think about grief after a death. Sadness, difficulty sleeping, loss of appetite are all expectable, right? But if grief leads to persistent hallucinations or delusions long after the initial shock, the source suggests that could be disproportionate severity, potentially indicating an internal dysfunction.
Okay, that makes sense.
Similarly, intense sadness after a breakup is normal. But if crippling depression lingers well beyond the persistence of the stressors, as the book puts it, that could indicate an internal dysfunction. Compare that to feeling nervous before a major exam, totally expectable.
Right.
Versus crippling anxiety that persists for months after you've already passed and, say, received tenure. The trigger's gone, but the response stays, or is way out of proportion.
So it's not just the feeling itself, but the why and the how long or how intense relative to the situation.
Precisely. The source uses another vivid example, wrestlers who meet the symptom criteria for bulimia during wrestling season. They're rapidly losing weight for a match, maybe binging afterwards. According to the author, this is behavior driven by conforming to the extreme social demands and expectations of their sport for a specific period.
Okay.
It's not presented as an internal dysfunction or a mental disorder in that context, even though the symptoms technically tick the diagnostic boxes.
That example really drives home the author's point about context being critical, and the symptom-focused approach ignoring context.
Well, it seems to lead to a huge problem when we try to figure out how common mental disorders actually are in the population.
It does. The source argues forcefully that community surveys, like the large epidemiologic catchment area study, the ECA or the National Comorbidity Survey, NCS,
Yeah, I've heard of those.
which rely on the symptom-based checklist logic without adequately accounting for cause or context, end up vastly, dramatically overestimating the prevalence of mental disorder.
And the numbers they report are just staggering, aren't they?
They are. You hear estimates like 1/5 of the U.S. population having a mental disorder yearly, and nearly half having one at some point in their lifetime.
Half the population. Wow.
Specific rates often cited are around 10% yearly for major depression, about 20% lifetime for anxiety disorders, and really high rates like 24-28% for substance abuse or dependence.
So nearly half of us will be mentally ill at some point. The book pushes back hard on this, right? It questions those numbers. It does. The source presents counter-evidence from studies that apply much more stringent criteria for serious mental illness.
Okay, what counts as serious?
Looking for things like actual psychosis, major depression requiring hospitalization or serious medication, attempted suicide, or substantial long-term impairment in work or relationships. Things that really disrupt life significantly.
Right.
These studies find vastly lower rates. The source cites estimates of just 2.6% for serious and persistent mental illness and maybe 5.4% for serious mental illness overall.
That difference is shocking. Nearly 50% lifetime versus maybe 5% serious. That highlights the magnitude of the overcounting, according to this author.
Exactly. That's the core of the argument about prevalence.
So who benefits from these incredibly high prevalence estimates being generated and, perpetuated? Why do these numbers stick around?
Well, the source points to several stakeholders with clear incentives. Pharmaceutical companies, for one, see enormous potential markets for drugs. The author uses the example of Paxil being approved for social phobia, arguing it effectively medicalized ordinary shyness,
Right.
creating a huge market by suggesting millions had a treatable disorder.
So take something common like shyness, give it a clinical name like social phobia, and suddenly millions need a pill. Is that the idea?
That's the argument presented, yeah. Advocacy groups also use these numbers to justify their efforts and argue for increased resources, framing mental disorders as a widespread danger to public health. Mental health professionals might see it supporting the narrative of vast unmet need, which increases demand for services. Researchers and agencies can secure funding by highlighting the immense scale of the problem they propose to study or address.
And does the source suggest any broader societal consequence, maybe even an unintended one?
It notes that these high estimates might, in one sense, help normalize talking about mental illness, which could be good by showing it affects such a broad population. However, it also raises the concern that people might start interpreting their own normal nervousness, sadness, or stress reactions as clinical disorders, precisely because the classification system and the high prevalence numbers tell them these common experiences are disorders.
Which perhaps explains why many people dealing with distress don't actually seek formal treatment.
Right. The source's counter-perspective is that many individuals appropriately understand that their distress stems from external circumstances, relationship issues, job stress, financial struggles.
Yeah, life stuff.
And they reasonably expect that the distress will lessen when those circumstances improve. The book even cites data suggesting that many users of mental health services are experiencing significant distress, but do not actually meet the formal criteria for a diagnosable disorder, according to even the broad DSM standards.
Interesting.
They're seeking help for life problems, not necessarily internal dysfunctions as defined by Horwitz.
This perspective really forces you to think differently about where distress comes from, not just inside someone, but how much it's shaped by the world and culture around them. The source goes even further, doesn't it? Arguing that distress isn't just influenced by culture, it's actually structured by it.
That's a fundamental argument. Cultures provide what the source calls legitimate scripts and shared meanings. These frameworks don't just subtly nudge how you feel, they shape how you perceive, interpret, express, and even experience symptoms.
How so?
They channel general human vulnerability or distress into specific forms that are recognized and make sense within that particular cultural context.
Like historical examples.
Yeah.
Disorders that seem to appear and then disappear with cultural shifts.
Hysteria in late 19th century Europe is a classic example given in the source. It manifested with various physical symptoms, paralysis, fainting, fits that had no clear organic cause.
Right. Freud studied that.
Exactly. It was central to early psychoanalysis. But as new psychological ideas and cultural idioms emerged, hysteria as a widespread phenomenon essentially declined. The script changed.
And are there modern examples of these structured disorders according to the book?
Multiple personality disorder, MPD, later renamed dissociative identity disorder, and the related phenomenon of recovered memory syndrome, RMS, are presented as significant recent examples.
Oh, yes.
The source details a dramatic surge in MPD cases after the popular book and TV movie Sybil in the 1970s, going from only around 200 recorded cases before 1979 to over 20,000 by 1990,
20,000, wow.
with some proponents claiming up to 2 million cases existed.
That is an astonishing increase in such a short time. How does the book explain that kind of, well, epidemic?
The source argues this epidemic was powerfully fueled by a specific structured narrative, often linked to recovered memories of childhood abuse. This narrative resonated strongly, particularly with women, who constituted about 90% of the sufferers. The author describes MPD during this period as a nearly pure case of an iatrogenic disorder.
Iatrogenic meaning caused by the treatment itself.
Essentially,
Yeah.
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 Created or spread by the treatment system, promoted through clinical suggestion, therapeutic attention, support groups, media portrayals.
And similar to hysteria, did its prevalence also decline?
Yes. As the founding narratives, like the specific case presented in Civil, were questioned or unmasked, and as skepticism grew and counter-movements arose, the prevalence of MPD-ID diagnoses also significantly declined. The cultural script lost its power.
What about disorders that are considered more central and stable in modern psychiatry? Are they also seen through this cultural lens in the book?
According to the source, yes. Eating disorders like anorexia and bulimia are presented as core diseases in contemporary psychiatry, but the book argues they are also heavily structured by culture.
How so?
While there might be underlying individual vulnerabilities, genetic, psychological, these vulnerabilities are channeled into these specific forms. The intense focus on body image, thinness, dieting, and exercise. Why? Because of pervasive Western cultural emphasis on these things. And this is reflected in who is most affected, predominantly young, white, middle to upper middle class females. The culture provides the specific blueprint for how underlying distress gets expressed.
So culture doesn't just add flavor, it provides the very template for how certain types of suffering manifest. The source also points out that social factors aren't just structuring distress, they can directly cause it, potentially even leading to those internal dysfunctions if the symptoms persist long after the initial stressor.
That's another critical point.
Yeah.
The book cites sociological research highlighting the causal role of social factors, particularly for non-psychotic forms of distress. While maybe less influential for severe psychoses like schizophrenia, social environments significantly impact conditions like depression and anxiety.
What kind of evidence does it present for that?
Well, it mentions classic work like Durkheim's findings, linking suicide rates to levels of social integration, showing that distress isn't just individual, but tied to collective social bonds. A key longitudinal study from New Jersey, cited in the book, found that marital dissolution, divorce, separation, caused significant increases in depression and alcohol problems, even after controlling for the individual's prior psychological state.
Meaning the event itself was a causal factor, not just something that happened to people who were already vulnerable.
Exactly. The social experience itself can, well, make you ill, or at least significantly distressed. Studies also show how power dynamics in relationships are linked to distress. Particularly for women in less powerful positions like housewives compared to employed wives, though the source notes this isn't static as gender norms change, like increased female employment. These distress patterns also shift.
Interesting.
And birth cohort studies show generational effects, suggesting distinct historical periods and social experiences shape the prevalence and maybe even the type of distress among groups growing up in different eras.
It's really clear the social world is deeply intertwined with psychological suffering. How does this complex picture influence how we think about treatment, according to the source?
Well, the source contrasts psychotherapy and medication therapies. Psychotherapy relies heavily on cultural symbols, language, and the unique relationship between therapist and client.
Right.
It has roots in older philosophical or religious healing traditions. Its effectiveness, the book suggests, is deeply intertwined with the personal and cultural contexts of everyone involved.
And medication is seen differently.
In theory, yes. Medication uses physical substances acting directly on the brain and should be less dependent on personal or cultural factors. Give someone the right chemical, and it should work the same way regardless of their background or relationship with the prescriber. That's the ideal, anyway.
Evaluating psychotherapy sounds tricky compared to medication trials, then.
It is.
Yeah.
The source points out you can't easily do a true double-blind placebo-controlled trial for psychotherapy.
Yeah.
How do you blind someone to whether they're talking to a therapist?
Yeah, good point.
This makes it difficult to isolate the specific effects of a particular therapy technique from other factors that might be at play.
Like what kind of factors?
Like what's sometimes called the dodo bird, finding, from Alice in Wonderland, everybody has won and all must have prizes.
Okay.
It's mentioned in the source because many studies conclude that different types of psychotherapy seem roughly equally effective. This suggests, according to the book, that effectiveness might not come from the specific, unique techniques of, say, CBT versus psychodynamic therapy, but from generic social support, the beneficial aspects common to all helping relationships with a trained professional.
Yeah.
Like having a safe space, someone listening attentively, offering hope, a structured approach. The relationship itself might be the key ingredient.
That's a really interesting thought. Maybe the specific brand of therapy matters less than the supportive relationship. What about challenges and implications of medication from the source's perspective?
Well, while medications can certainly provide relief for symptoms, the source argues their effectiveness is still influenced by cultural expectations and the system in which they're prescribed. Placebo effects are real, even with drugs. But a more fundamental point the book makes is how they're used across diagnoses. It highlights that the same medications, particularly drugs like SSRIs, the common antidepressants,
Right.
are prescribed for a remarkably wide range of seemingly distinct conditions: depression, anxiety, anorexia, panic disorder, substance abuse, even things like PTSD or OCD.
Wait, the same type of pill for all those different conditions?
Often, yes.
Right.
And the source argues this suggests these drugs might be primarily alleviating general distress or unhappiness
Oh.
rather than targeting specific, discrete disease entities caused by unique biological malfunctions, as the diagnostic model implies.
Right.
This wide application across many diagnoses seems to run counter to the core logic of diagnostic psychiatry, which proposes distinct conditions needing distinct treatments.
That mismatch is significant. And how do external forces, like the healthcare system itself, influence this whole picture? Insurance and things. Expert speaker heavily. The source argues that external factors, particularly managed care and insurance reimbursement policies, strongly reinforce the diagnostic model. Insurers prefer to reimburse for discrete disease entities, something quantifiable, seemingly medical, right?
Statistic.
Expert speaker, exactly, rather than vague suffering or long-term talk therapy. They also tend to favor more cost-effective medication over potentially lengthy psychotherapy, further embedding the diagnostic, symptom-focused framework into everyday practice. And the book also notes the public's perspective plays a role in what we collectively agree to call a mental illness, doesn't it?
Yes. The public, the source argues, tends to be more skeptical of classifying what they see as social deviance, things like drug use, criminal behavior, maybe even just extreme nonconformity, as diseases stemming from internal dysfunction. They often view these behaviors more as matters of choice, morality, or social problems, which frequently clashes with diagnostic psychiatry's tendency to medicalize a broader and broader range of human behaviors and experiences.
So stepping back, this deep dive into Horwitz's source material really challenges our everyday assumptions. It shows that defining mental illness isn't some simple, objective medical process,
Not at all.
but a complex outcome shaped by symptoms, certainly, but also by social context, powerful cultural narratives, historical shifts in psychiatric models, economic pressures from the healthcare system, and even public perception. It's messy.
It absolutely highlights that what gets labeled and treated as mental illness is much more fluid and contested than those neat symptom checklists might suggest. The source specifically urges us to question symptom-based classification, especially when those symptoms look a lot like expectable, understandable reactions to difficult, stressful circumstances in life.
It leaves you with a profound sense of how much the container of diagnosis itself shapes what we see and how we respond to suffering.
It absolutely does. And it raises a really important question, I think, for you, the listener, to sit with after this deep dive. Given this perspective that psychological distress is influenced by both potential internal factors and these external social, cultural, and systemic forces,
Yeah.
how do you think we should best distinguish between what's just normal, albeit painful, human suffering, the sadness, anxiety, and difficulty that are part of life, and what constitutes a true mental disorder? What are the potential benefits and perhaps the potential drawbacks of labeling an ever wider range of human experiences as disorders?